And now I'd like to open it up to questions and answers, some of which have already been sent to us. We'd like to talk about those or answer those first. And then if you'll just raise your hand, we'll allow those of you who wish to ask me a question for me to directly answer you. So with this, I'll turn it over to Kate, who is going to sort of explain the question and answer logistics. Kate?
Hi, everyone. Hopefully you can hear me. We have two ways to submit questions. We already have two questions that have been submitted via chat. In addition, if you would like to go down to the bottom browser bar where you see participants and click on that, there should be an option for raising your hand. If you right click on more, also the slideshow, here we go. So click raise your hand at the bottom of the window, raise your hand. Otherwise, and that will give you time, I'll unmute you and you can ask your question back and forth with Dr. Lasasso, and you're not just limited to what you've put in the chat. However, if you've put something into the chat and the question is not answered completely, please feel free to follow up with, I have another question. So on that note, we're going to get started with our first two questions, and I do see a successful hand raise, so hopefully everybody's on the plan here. So our first question is the sternum, Dr. Lasasso, is the sternum elevated from outside before the bar is inserted?
Great question. Great question. And that has to do with using techniques to lift the chest in cases where the defect is very, very severe and causing the surgeon to have difficulty seeing that critical interface between where the chest wall is sunken and where the heart is located. Sometimes that is easy to see. Sometimes, due to severity, it's difficult to see. So those of us who do this operation are trained on the use of a retractor, a piece of equipment called the rule track retractor that allows us to lift the chest forcefully using this retractor, which then adds better visualization and safety to that critical part of the Nuss procedure where the chest wall and the heart need to be identified and somewhat separated from one another, because it's in that space between my hands where the bar has to be positioned. And so in some cases, the use of forceful sternal retraction is necessary. So that's an important thing for each and every patient and patient's family to ask of their surgeon and make sure that he or she is aware of that technique, knows when that technique is necessary, and has the skill, experience, and training to use that instrument to maintain safety for all patients.
Perfect. We hope that answers the question, but if it doesn't, please feel free to raise your hand and continue and ask more questions, or send us a more detailed question in chat. Our next question is somewhat specific, but we'd love to answer it. And along that lines, if you have a question that is not related to pain management, please feel free to raise your hand or submit the question as chat as well. We're happy to answer any questions tonight. Try to keep it a little less specific than in my current situation, blah, blah, blah. But even those, we'll discuss it. And some insurance billing questions might be better answered by calling our office. That information is on the website. But otherwise, please feel free to ask any and all questions tonight. So here we go with our number 2 question via chat. I know it is patient specific, but can you please explain the pain plan for a healthy 21-year-old patient with a high Haller index? Would you use a combination of these? Are there any pain options that you reviewed that cannot be used together? Would you treat an adolescent differently?
Would I treat what differently?
An adolescent.
An adolescent differently. Good questions, very good questions. So I'm going to talk now about my personal strategy, okay? This is how I do it. It's not how everyone does it, so I want to be clear on that. But at this moment, whether a patient is an adolescent or an adult, my mode of pain therapy is the same in terms of its general outline. The specifics, i.e., how much of a medication I might use, would be different from an adolescent versus an adult, but the general outline would be the same. And that would include multimodal drug therapy that we've discussed. You know what that means now, combined with the use of Exparel to accomplish intercostal nerve block, following which a patient would receive some narcotic in the form of patient-controlled analgesia in the immediate postoperative period, which would generally be discontinued within about 24 to 36 hours after the patient's procedure is completed, and replaced with the oral form of a narcotic, which would be Percocet in my practice, and combine that with the other components of multimodal therapy, which would mean Tylenol, Motrin, gabapentin, and Valium. And those would be continued for, in the case of narcotic, for a week post-op, and most people don't even need it for a week. And the other medications generally can be weaned and discontinued within 2 weeks to 3 after the procedure, after the discharge of the patient from the hospital. And that is my general outcome, and I do that for both adolescents and adults, but I tailor-make the dosing and duration to the patient specifically. And in my practice, I have the great fortune of a wonderful pain management team that I partner with, who's part of my treatment team, who sees all of my patients preoperatively and assesses what their pain history and projected needs might be specifically, and has a conversation with the patient and their family regarding some of the basic medicines and techniques for pain management. And then they become part of my day-to-day team, seeing the patient every day during the course of their hospital stay. And we partner together to refine the general outline to create the most effective pain management plan on a day-to-day basis until the patient is discharged, at which time I take over the pain management, but there's always the option and opportunity to consult with the pain management team and the pain management physicians with regards to specific questions that I or the patient or the family may have. I find that to be a tremendously, almost invaluable resource in managing an individual patient's pain through the continuum of care.
Stephanie, hopefully that answered your question. If you have a follow-up question, please feel free to raise your hand or add more questions to the chat. Kim Zuck, you're next up for questions. I'm going to unmute you and lower your hand. And if you want to turn your own video on, please feel free to.
Hello, can you hear me okay?
Absolutely.
Yes,
Awesome, thank you. Thank you. So my daughter had a Ravage done at age 5, and she's the one that put the question in the chat. And that was in 1996. She's about to turn 30, and it did reoccur around age 21, 22. I think her Haller index was close to 3.2, 3.3. Just have you had any experience with doing a Nuss procedure post-Ravage? She does have a lot of scar tissue and restrictive airway disease. We're trying to figure out what would be best for her.
The answer specifically to your question is I have seen that, and I have treated that problem. It's an extremely difficult problem to treat because the Ravage procedure, as part of its treatment strategy, was predicated on the removal of components of the chest wall. And as a result of that removal of native tissue from the chest wall, the body responds in a way that is very non-anatomic, okay? And by that I mean when the deformed ribs are removed, the patient can either regenerate some of the original cartilage, depending upon the skill and the meticulousness of the surgeon who did the original Ravage, or can have no cartilage and just scar tissue that makes up the entire anterior part of the chest wall. So everyone who's undergone a Ravage is unique unto themselves. And so it requires a complete reevaluation of each individual post-Ravage patient regarding what their post-operative anatomy is and whether or not a Nuss procedure to correct the recurrent or persistent Pectus excavatum is indicated. So I think that I would leave you with this, that your daughter is very unique now that she had a Ravage procedure and it has led to recurrence, and she would need to be fully reevaluated specifically in order to answer the good questions that you now and she now have. So I have done repeat surgery on patients who have had Ravage and used the Nuss procedure in some very limited cases to reconstruct those patients, but it's not something that I do a lot, and it's not something that anyone should do a lot, because it should be done with great care and great forethought, and it should be done by someone who's experienced in doing these kind of very complicated redo operations. So I would say if you wish to discuss this further with me, please reach out specifically to me and to my office, and we could talk about your daughter's condition specifically.
That would be great. Thank you so much.
You're welcome.
Dr. Lasasso, we have another question coming up from chat from Jessica Brogdon. And quickly, I just want to tell Jessica, this is somewhat of an athletic related question. And we did do a specific webinar about 2 months ago where we had a roundtable of young athletes, both high school, college, who were at the top of their game. and they participated in a live Q&A during that session. And that is recorded and live on our website at nussprocedure.com under our webinar recordings. So that might be very interesting for you and your son to listen to as well. Dr. Lasasa, the question is, my 17-year-old son is a competitive golfer at the national level. He is hesitant to pursue the Nuss procedure due to the bar's potential limitation on rotation needed for the golf swing. Do you have any history of surgery with golfers or insight regarding his concerns?
Well, let me say this, that I personally play golf, so I understand the game and the mechanics of the game. I've operated on many young men and women who are golfers, none of whom were sort of world-class, high-level, competitive golfers, but I've operated on enough individuals who play the game, love playing the game, and wished to play the game during the course of their therapy to know that it is possible to have your chest wall corrected and play the game of golf. So I think it would be, again, important to understand more about the specifics of your son's condition to be able to really give you the full benefit of my opinion regarding his situation specifically. But in general, I can tell you that I have operated on patients who are golfers, and they continue their love of the game and playing the game. And none of them ever came back to me and said, you know, I just am not playing the game as well now that I've had the Nuss procedure. So I've never had anyone tell me that. And I would echo what Kate just said. I think one of the most gratifying things that I have done in the course of my career doing the Nuss procedure is working with very high functioning athletes of almost every kind. And I have found them to be some of the most motivated of my patients in terms of the enthusiasm with which they approach the recovery phase of the journey. And it's been so gratifying to work with these young men and women, and a cross section of them were kind enough to spend an evening with me and share their stories. And it was one of the most well received of these webinars that I've done. So I would encourage you to follow Kate's suggestion and read a little bit. Expose yourself to that material. It's on my website, and I think you'll find it, and I think your son will find it very informative. But in terms of your own son's condition, I'd be more than happy to see you and give you my specific recommendations once I've fully evaluated your son.
I'm currently inserting the link to the webinar that we did with a number of professional athletes, baseball players, college level professional athletes, baseball players, swimmers, surfers, volleyball players in the chat. If you guys want to click on that when we're close to done, and that way you'll have the link. It's going to go in right now.
I'd like to digress for just a second because this thought just came to mind. I would really love I see that I have 31 participants at this point in time, and I'm thankful for each and every one of you. And the way that you all can help me is tell me what you're interested in knowing. How can I help you and your family in this journey? We have our own sense of what you might want and need to know, but it always helps us in creating our curriculum to know what you, the audience, want to know. So if there's something that I haven't covered as of yet, or something that you really need more clarity and information in order to assist you in your journey or that of a loved one, please let me know that. Go to my website, send me an email, reach out to my team, and let me know what you are interested in, and I'll try to direct future webinars to those topics specifically. And thank you for that participation.
Dr. L, here we are on our next question. How do you feel about the use of stabilizers on the bars?
Well, again, I'm going to talk from my own personal experience. I was taught by Donald Nuss directly. And Donald was always very, very adamant that there was value added in using a stabilizer. I use a stabilizer if I can. Sometimes the chest wall just doesn't allow the bars to be positioned in the way they need to, and a stabilizer to be applied to even one of the two bars. But if I can, I put a single stabilizer on the bar that is bearing the most weight of the chest. So more often than not, I put more than one bar in. I don't always, because my goal is to use as few bars as possible to accomplish my objective. My objective, simply put, is to lift the chest off the heart. And I know what that means because I've done this a lot. And I can see very clearly when I've accomplished that goal. When that goal is accomplished, that's the end of insertion of hardware. So in an instance where I need to use more than one bar, I try to put at least one stabilizer on the side opposite-handedness on the bar that's bearing the most stress and the most weight of the chest. Again, that's also very easy to discern in your experience. And on the other bar and on the other side of the stabilized bar, I use sutures placed in a very precise fashion that go around the bar and an adjacent bony rib. If you'll give me a minute, I'm going to use a prop. Just 1 second. A Nuss bar. Okay? This is the end of the bar, and this serration is where the plate or stabilizer is fixed. On the opposite side of the bar, I place two around the bar and the bony rib, which is my index finger, as the bar crosses over the rib. Think of it almost like a zip tie around the bar and the bony rib that fixes the bar to the rib and really serves as a replacement for the stabilizer on the side opposite to the stabilizer, meaning on the side that the patient uses the most. For most people, the right side. So for most people, on one bar, the bar under the deepest part of the deformity, there's a left-sided stabilizer and a right-sided two-stitch fixation of the bar to the underlying bony rib. On the other bar, I use stabilizing stitches through the end eyelets, like everyone else does. Plus, on both ends, I put the deep stitches that I like to call zip ties around the bar and the bony rib, where the bar crosses the bony rib. That's a very easy thing to do when you're experienced and you have the equipment necessary to accomplish that.
Thank you, Dr. Lasasso.
That's my personal way of stabilizing the bars. And I will say this, that if one does the operation properly, there should be 0 incidence of bar migration. Bar migration in the proper hands should never happen. So it's important for all of you in contemplating the operation to be clear on how your individual provider is going to ensure that the bar, once placed, doesn't move. That's very, very important. And the answer to that very important question will differ from provider to provider. It's up to you as the patient to hear the explanation and be comfortable with that explanation and know from that physician that their results would suggest that the incidence in their hands of bar migration is near 0.
Thanks, Dr. Lasasso. We have another question here. Is this surgery a huge learning curve for thoracic surgeons? And if so, how many surgeries is ideal for a surgeon to achieve that learning curve in adolescents specifically?
Well, that's a great question. So
I know you're going to love this one.
There's many aspects to that question, okay? First of all, I would say that if you're an adolescent and you have a pectus deformity, my bias is that that individual and family should be evaluated by a pediatric surgeon that is very experienced doing the Nuss procedure. I think that would probably be my first 3 choices for that patient and family. And there are ample pediatric surgeons all over the country who are as committed as I am to doing this operation and doing it at the highest level possible. So there's no reason for anyone to feel like they can't, if they are the parent of an adolescent, that they can't find an excellent, experienced provider who, as a matter of their professional focus, does chest wall reconstruction on young adults. I think that would be what I would hope and wish for every young adult in the world, let alone in the United States. For older patients, for adult patients as defined by greater than 21, there are some pediatric surgeons like me that operate on adults in the area of chest wall deformity. And there are adult surgeons who have spent the time and have the interest in knowing how to do the Nuss procedure effectively and safely. And I would wish for adults in the world and in America to find those providers, because it's important that every person undergoing a Nuss procedure has an experienced, well-trained surgeon with a team of dedicated professionals around them, providing this very, very, very special and demanding care. I've devoted my entire professional life to this, and I think that that's the kind of provider with that kind of focus that each patient deserves. And it's now up to each patient and their family to find that provider.
Dr. Lasasso, another question is regarding another young athlete. My son is a 12-year-old and is a soccer goalie on a competitive soccer team. How long would he be on the sidelines after the surgery? Would he be able to return to playing goalie with the bar in?
The answer is yes. Your son could return to playing soccer as a goalie. I understand that there is contact involved in playing soccer in general and that position in particular. But I think that a patient who has undergone the operation and has had a successful operation can return to that activity. Now, I would say this, that anyone who has had the operation needs to both fully recover, obviously, and part of full recovery is engaging in both a generalized program of physical therapy, and on my website, I have a physical therapy program that I spent some considerable time working with a very experienced and gifted physical therapist in San Diego when I was there. Kate Grace is her name. She works, her practice is called Evolve Physical Therapy. And together we came up with what we thought was an excellent program for the rehabilitation of patients who have had the Nuss procedure. That, I think, is an excellent outline for anyone, anywhere looking to recover from a Nuss procedure. It's a series of exercises that are specific to the area that is most in need of rehabilitation, that is sort of staged week by week in increasing difficulty to accomplish a full recovery from the operation. Our program requires twice a week physical therapy for an hour at each session, done over the course of 8 weeks, starting at about 3 weeks, 2 to 3 weeks, depending upon the patient, after discharge from the hospital. So it's about 16 sessions over 8 weeks of physical therapy. At that point, I think everyone who's an athlete needs to see their surgeon and be evaluated again as to how that recovery in physical therapy has gone and how the patient is feeling and performing. And then jointly, a decision could be made as to whether or not you can proceed with sport-specific exercise. And for each sport, that's a different repertoire of activities. And so I work with my athletes and the patients who are very committed to their form of sport and exercise to come up with a way of reintegrating them into their normal exercise routine and sport. And generally, from that 3-month point to a point somewhere around 5 to 6 months, depending on the sport and the athlete, one can resume doing sport-specific competition. Okay? And again, you can't, it has to be specific to the sport and the patient. So I can't give any broad general guidelines, but to say that these are the general outlines for me in my experience and my practice. But it's generally 3 months of 3-month interval of physical therapy, 2 months of sport-specific retraining with competition at about 6 months post-op, even with sports that involve contact.
Thank you, Dr. Lasasso. Here's a question for us. And again, we've done a webinar specifically related to the difference in the Pectus journey between adults and adolescents. But specifically, how long is the recovery from adult after a Nuss procedure? What are the limitations for the individual while the bar is in?
Great. Well, it's very similar to what I just said for the athlete. Essentially, the adult should expect to be able to, be out of the hospital in 3 to 4 days. That's after surgery. So surgery plus 2 to 3 additional days. And then at home, I generally say return to work 2 to 3 weeks later, depending on the nature of the adult patient's work. Clearly, back to work is sooner if you do, sort of a desk job versus if you're more active in your line of work. But 2 to 3 weeks, I think, after surgery is an appropriate interval to be back to work. And then I would say I've already answered the activities that that an adult would be inclined to do and would be allowed to do. You would be able to walk and be encouraged to walk and deep breathe for the first 2 weeks that you're out of the hospital. Start physical therapy at 3 weeks. That would proceed until you reached 3 months post-op. At 3 months, you'd be reassessed, and depending upon what your individual interests are and the things that you wish to do, both in terms of your free time and in terms of the workplace, would be a conversation that I would have with you, and we would work together to figure it out and get you back to doing anything and everything you wish to do within reason, somewhere between 3 and 6 months post-op.
Thank you. We have another stabilizer question, Dr. Lasasso. I have heard that stabilizers can contribute to feeling the bars and more pain. How would sutures around the ribs work instead of stabilizer bars?
Well, they can be an equivalent. I think it just depends on the individual patient, on the individual patient's chest wall, conformation. And so I've tried to honestly answer that question by saying that if I can, I use one stabilizer. I don't feel that it contributes at all to increased pain. That's my personal opinion. I think pain more often in the postoperative period is due to inadequate pain management or a bar that isn't properly placed or isn't properly configured and bent. Remember, the bar is bent to conform to the dimensions of one's chest wall. There's art involved in that. There is experience involved in that. And the degree to which the surgeon can bend the bar as perfectly as possible to match the configuration of your chest and place the bar in its proper position to optimize the working of the bar in your chest, the more effective the implant will be to correct the deformity and the less pain you will feel with the implant in place. So this idea that stabilizers cause pain, I think is misguided and I think inaccurate. I think there are many other things that lead to postoperative pain that don't involve whether or not you have a stabilizer. In my opinion, a stabilizer applied in the fashion that I've described has much more upside than downside. Again, that's my opinion, but my opinion is shaped by 20 years of experience and being trained directly by Donald Nuss.
We're happy to discuss this more as well. If anybody has more stabilizer questions, you can always schedule an appointment via our website to either discuss with Kim, our patient coordinator, or with Allison, our physician assistant. So the next question, what causes the bar to flip?
I think I just answered that. I think it is the bar not being shaped properly, positioned in the chest properly, and secured within the chest properly. It can be any one of those three things. And sometimes it's all of the above.
Dr. Lasasso, the next question is great in regards to our current webinar. And I know after having spoken to a number of our patients who have had very little pain management after a first couple of days needed at all, because of the treatment that you do you have any insight on pain management with regards to alternative medicine such as acupuncture if patients decide not to extend taking cocktails of pain medication?
Well, let me say this. I am very open to discussing with individual patients their individual ideas and suggestions with regards to their individual pain. And to be honest, over the course of my 20 plus years doing the Nuss procedure, there have been instances where patients have come to me and asked if gentle massage or stretching or acupuncture could be potentially helpful. And once I vetted who they were going to receive those therapies from, and I was convinced that the individuals who were offering those therapies understood the operation that was done to the patient. I have in the past, on occasion, been more than willing to have the patient use those other modalities for pain management. I think they have a place in the management of pain, but again, I don't have an acupuncturist that is, a part of my standard management routine. I do not. But I have at times had patients who are interested in using that modality, and I think in some patients and in some instances it can be very helpful, just to speak specifically about acupuncture.
Great, thank you, Dr. Lasasso. I'm also pasting a link, and this will loop back around to all of our patient testimonials and blog posts about patient stories. But we worked with Max, who is a professional oboist, and I took down his story before we wrote the post, and he was amazed by how little cocktail of drugs he needed to take after surgery and how fast he was able to return to practicing, traveling, everything. So I'm going to post that link in the chat as well for anybody who's interested, because that's what we're trying to do, is decrease the amount of pain meds that people have to take for an extended period of time. And this is a patient testimonial that might speak to that question, whether it's acupuncture or anything else.
Yeah,
all right.
I would just say, I would just echo what Kate just said, that our North Star, our guiding principle in our practice is to use as little narcotic as possible and as little pain medication for as short a period of time as possible. And I would just say to all of you out there that anyone who's interested in talking specifically to me about pain management or to my patients with regards to how their pain management course went, I have ample number of patients who have been generous enough to volunteer their time to tell their stories and to tell how their pain management outcomes went. And so I would say, for those of you out there who are interested in that, I'd be more than happy, my staff would be more than happy to share those patient names and contact information with you.
Dr. Lasasso, have you had Pectus patients with scoliosis who had the Nuss procedure? Did the bar improve or worsen the curve of the spine? Also, were there any additional problems or pain during the years before bar removal?
Well, the answer is that in my experience, the scoliosis associated with Pectus in general tends to be mild and seldom requires its own separate operation to address. In my experience, patients with scoliosis tend to improve, if not at least not advance, in terms of the severity of their scoliosis as a result of having the anterior chest wall deformity corrected. So I wanna not overpromise here. I'm not saying that a Nuss procedure corrects scoliosis. It doesn't. But I also want all of you out there who may have some degree of scoliosis as part of your overall anatomy to know that the scoliosis is generally not that severe, and the further progression of the scoliosis, depending upon your age and when you might be able to have a Nuss procedure, will surely help to prevent further advancement or worsening of your scoliosis if you're young enough that you're still growing and your chest and your back are still evolving. In that setting, a Nuss procedure can be very helpful in preventing further worsening of the spinal deviation.
Dr. Lasasso, do you repair rib flare at the same time as the Nuss procedure?
I don't. I think that's in my opinion, again, it's not necessary. In most cases, rib flare, just like the rest of the chest, gets better over time. So I'm a less is more practitioner of the art of surgery. And I believe that trust the Nuss procedure to address not only your sunkenness, but your rib flare. Give that time. And then if at the end of your course of treatment with just the Nuss procedure, you feel you have rib flare that is unacceptable, then at that point in time, things can be done to improve that. Some of it's surgical, but more often than not, it's just bracing. And I think that this idea of doing more surgery than a Nuss procedure because of early rib flare after correction is misguided and unnecessary. Again, my opinion.
Dr. Lasasso, on the cases that you've done a second repair following Ravage, have they had improved lung capacity or has it just been a cosmetic repair?
Well, so now that question, I'd like to rephrase that question. That question is asking me about the physiologic benefit of the Nuss procedure. And unfortunately, the Nuss procedure, even though it's been done for 20 years, is unfortunately not been well studied in terms of the physiologic effects after the procedure. Excuse me. But what we do know is that there's some evidence that the Nuss procedure does improve the flow of blood and the efficiency of flow of blood between the heart and the lung. And it's there where I think the money is. I don't think the Nuss procedure benefits patients physiologically by changing lung volume or airway physiology. Doesn't work that way. But I would say that if there is a beneficial effect, and I believe there is, the effect is more on blood flow through the heart and to the lungs than it is anywhere else. And there is some anecdotal evidence, but not well studied, that the correction does positively affect cardiac blood flow, but not well studied.
Thank you, Dr. Lasasso. The next question, the person's left the room, so I'm just gonna do a good redirect here. The question was, how much is the procedure without insurance? That is a question that is best answered by the office. It depends from case to case and hospital to hospital. We do plan to have an upcoming webinar specifically regarding navigating the waters of insurance and payments and issues like that. So hopefully stay tuned to that when we get it scheduled. But please, please, please feel free to call the office and ask any insurance questions. They come up a ton, and we know how important they are. And we think about it every day, and we are happy to help. So next question after that one, Jordan's already left the room. Sort of also an insurance question. Some people consider it cosmetic. What do you recommend for patients who have pectus, mild, moderate pectus with no complications but are seeking surgery and have insurance barriers due to low severity and no physical harm? We have had a lot of patients that have overcome a lot of insurance barriers. Dr. Lasasso, do you want to speak to that for a minute?
Man, I think you've done a great job, Kate. I think you pretty much summarized it. I would just say this: do not be discouraged. Okay, do not be discouraged. Do not allow insurance companies to get in the way of you at least fully evaluating your physical condition. This is a physical condition, okay? How it is affecting you requires a very comprehensive evaluation involving radiologists and cardiologists and pulmonologists, sometimes geneticists. There's a lot that each individual with a pectus deformity needs to know about their individual medical situation. Start there. Start there. Find somebody who has the wherewithal to fully evaluate, okay? Not just examine you personally, but has the ability to send you to the appropriate specialist to be fully evaluated. Once that evaluation is done, and if you have a deformity that does not meet the standard of care for correction, then that's a bridge you'll have to cross. But don't assume that that is who you are until all the workup is done, okay? That you should promise yourself and your loved one, your parent, before you get sort of caught up in, can I afford this, or what will I do if insurance places obstacles in my path? The other thing I want you to know is that anyone who's doing this at a high level has very skilled people within their organization to help all of you navigate the incredibly complicated, confusing, and somewhat adversarial world of insurance, medical insurance, that we all find ourselves in. My heart goes out to you. No one knows how difficult medical insurance and insurance companies can be than I. So I want to help you. I've tried to assemble very good people to help you, and I'm there in any capacity that I can be to help you with this very difficult part of the journey. But it's only part of the journey, and don't put it before the more important part of the journey, which is to learn as much as you can about your individual chest wall and how your chest wall is affecting your health. Once you have all the information that you need, then I think you can, reach out to people like me or me personally to help you with this next phase of approval. And the question implies that you may not qualify, and also that based on medical criteria, you don't really require a surgical correction. And I think you need to be open. Each individual and each family needs to be open to that as being a possible outcome of the process. But don't assume anything. And know that there are a lot of people out there who are committed to helping you through this journey.
Right. So I think that wraps up our last question for the night. Does anybody have any further questions? Again, we really encourage people to reach out to Kim and Allison via the website, via calling our number at the office. And I've pasted a number of links into the chat regarding past questions. And we look forward to our future webinar series. Dr. Lasasso, final words?
Thank you. Thank you for your interest. And know that there are many, many people in the medical field who are committed to helping you with your journey. Reach out to us, find us, reach out to us, and allow us to help you to reach the end of the journey in the most safe and effective way. It's my pleasure to be of any assistance to all of you. Thank you for your interest in my practice, and I want to wish you much health and happiness, and we'll see you next time.